I want to acknowledge some folks who have helped me with some of the work that I'll present today, and also some of the work was supported by the Greenwall Foundation and also the Mayo Clinic program in professionalism and ethics, who supports Jonathan Tilbert. These are the learning objectives, which are in your program. And I'm going to be talking today about stewardship, which comes from the Old English words for hall keeper. That is stig, space, and weird keeper. I especially like the weird part. And it refers to a responsibility to watch over and care for some kind of shared community resource, which apparently a hall was considered a shared community resource. And that's why they had stewards. But I'm talking more about healthcare resources and resources devoted to health and healthcare. And I think I added this actually over the lunch hour because a lot of people have talked about the sort of, unsustainable rising cost of healthcare, blah, blah, blah. And the numbers sometimes make your eyes roll over, but you and I, we take care of patients. And what we know is that patients are affected by the high cost of healthcare. In fact, noncompliance or non-adherence due to cost is probably the most common form of non-adherence and can affect up to half of patients. It's more likely to affect people with multiple chronic illnesses, and those who are in poorer health are likely to be less adherent because of cost. It's obviously more likely in those who don't have insurance for their prescriptions or who face higher out-of-pocket costs for whatever reason. Okay, here's a little graph that compares for you those who are uninsured, those covered by Medicaid, Medicare, private insurance, and the VA. And I don't think it would surprise anybody to see that the uninsured has the highest rate of non-adherence due to cost. That makes sense, right? They're going to face the highest expenses out of pocket. Medicaid being below, also not too surprising. The VA, however, has the lowest, lower than private health insurance. Oh, that sometimes surprises people. Obviously, folks with lower incomes are more likely to underuse medicine due to cost. It's more likely if they're under 65, women more likely than men, minorities more likely than non-Hispanic whites. And the other thing we know, and I know, that this affects health. Now we have studies to prove it. Okay, because as Dr. Bartlett pointed out, sometimes you need studies to prove something that you already know, right? And that is diabetics who reported cost-related underuse had worse blood sugar control, had more symptoms, and basically had poor physical and mental functioning. So I wanted to put this in here because this is about patients, and this is about what they face related to the cost of medical care. Now, yes, everybody else is paying for medical care too, but we're doctors, we take care of patients. I wanted to make sure that we emphasize their problems. So there are a variety of ways that people have proposed controlling healthcare costs, and I'm not going to go over these in much detail, but one way is to limit what's covered, the benefit limits, in other words, and that's kind of limiting by type of service. So, we'll cover intravenous antibiotics, but not diabetic shoes or something like that, right? So that's an example of that. Sometimes you can control spending by trying to control spending on capital and equipment, how many MRIs, how many beds, how many hospitals, et cetera. By the way, I apologize for my croakiness. I'd blame it on coming back from Canada, but I had it when I got there, so. You can control workforce. The quantity and the mix of healthcare workforce is another way of trying to restrain medical spending. Something called patient cost sharing, obviously, or what some people say, having patients have some skin in the game so that they don't overuse services. Of course, they don't tend to be always very good at choosing what they should avoid and use. So that's one of the things that the data shows us too. Administrative controls, and finally, the subject of my talk today, which is clinical decision-making or stewardship. The most expensive piece of medical equipment is a doctor's pen, or I suppose it could be a mouse now, okay? But this just looks so much better. We know that doctors' roles and responsibilities in cost containment are a matter of pressing concern. I call it a problem both urgent and enduring, okay? One of the questions that I sought out to try to answer with some of the work that I'll present to you today is, do most physicians agree they have a role considering costworthiness of medical services for individual patients? Professor Fleck was talking about that this morning. Do physicians report acting as stewards? Do they report considering resources when they make recommendations or judgments for physicians? And if so, what methods, what criteria do they use? How are they doing? Okay. So the aim of what I'm going to present to you, supported by the Greenwald Foundation, was to review the evidence about doctors' knowledge, attitudes, and behaviors related to stewardship, to analyze that evidence looking at 4 sources: the Code of Medical Ethics, the Charter on Medical Professionalism, the Ethical Framework of Clinical Judgment — I'll talk more about these in a minute — and also actual or potential impact on trust and trustworthiness. So, why these sources? Well, okay, I admit, full disclosure, transparency here, I'm on the Council for Ethical and Judicial Affairs of the AMA, and so we work on the Code of Medical Ethics. So I may be a little biased, but I think it's pretty important. It has provided guidance for practicing physicians, for medical boards, and for healthcare organizations for over 160 years, and was one of the sort of founding elements of the medical profession and the AMA. Okay, come on. All right. The Charter on Medical Professionalism, a relatively recent document that I believe Len referred to earlier, was authored in 2002, so quite recently, especially compared to the code, by the American College of Physicians, the ABIM Foundation, and the European Federation of Internal Medicine. And it's been endorsed by lots of other medical and professional organizations as well. So these are 2 just sort of sources of ethical norms or professional ethics, if you will, that talk about stewardship. Why examining trust and trustworthiness? Well, because that is the center of medical practice. The doctor-patient relationship is. In order to pursue health, his or her own good, a patient has to trust the physician with private information, hence the confidentiality stuff we have to do, and with his or her body, or his or her child's body in the case of, say, ECMO for neonates, okay? Trust in the healer is essential to healing, and trust, at least to some minimal extent, some minimal level of trust is necessary probably for someone to seek care at all. People who don't trust doctors at all, they don't show up. Now, I thought I had on here also the 4th one, the clinical rationing by clinical judgment, which was an article written by Simon Hurst and Marion Danis, I don't know, maybe 5 or 6 years ago, that lays out a framework for how physicians might think about resource allocation. And I'll describe it in a second. So here's some examples from the code. Now, the code has changed in this area recently. Before this started, it wasn't. I'm looking straight at Alan when I'm talking about this because he knows the story of the changes. And but because the evidence is what doctors know, think, and do in light of the way the code was, I'm not using the current content of the code. I'm using what was there, what has been there for a while. So here's some examples. Decisions regarding allocation of limited medical resources should consider only ethically appropriate criteria, including likelihood of benefit, urgency of need, change in quality of life, duration of benefit, in some cases the amount of resources needed, et cetera. And there's another opinion about managed care, speaking about doctors' duty of patient advocacy. So these are just a couple of examples. There's other parts of the code that speak to stewardship, but those are two of the big ones. So the medical professionalism charter, While meeting the needs of individual patients, physicians are required to provide health care based on wise and cost-effective management of limited clinical resources. Appropriate allocation of resources requires scrupulous avoidance of superfluous tests and procedures. And what were the 3 P's? Profligate and promiscuous, right? Okay, something like that. Well, they use different words, but also sort of hard to pronounce when you have a cold. All right, so what about trust and trustworthiness? Well, with trust, with a trust-based relationship, whether it's between a doctor and a patient or friends or student and a teacher, whatever, there come expectations of beneficence. That is, that the person you're trusting will do good for you. Expectations of advocacy, that they'll stand up for you, they'll speak on your behalf, they'll stomp their feet and make sure you get that X-rated A, okay, to use a medical example. Expectations of honesty, of integrity, and of competence. Patients trust doctors to be good at what they do, to abide by their professional ethics, and to look out for them, to look out for their behalf. And with that, with the professional integrity and ethics, comes a commitment to not just individual patients, but patients generally, to public health, to regulating our own profession, self-regulation, that's part of the definition of a profession, and some other things. Okay, so the framework for rationing by clinical judgment put forth by Danis and Hurst lists 6 elements to facilitate fair rationing: reciprocity, general concerns of justice, respect for individual variations. To me, this is really the most important part for doctors, because this is, I think, where we bring something to the resource allocation that nobody else can bring. Because we know our individual patients, we can help them decide what's best for them or what's good for them, and respect individual difference. You know, there's no such thing as that 70-kilogram man that we all learned about in medical school. Well, there might be a few of them around, but most people aren't the 70-kilogram man. And the evidence of the evidence-based medicine doesn't always apply to all the patients we see. So we have to use our judgment, and part of using that judgment is to be able to individualize care for our patients. Okay, so I might not, you know, get a certain kind of test for every patient who presents with a particular symptom. Say, I don't know, hoarseness. Why did that come to me? But for the patient of mine who's an opera singer, I might do it sooner. That makes sense. Okay, explicitness, consistency, and a review of decisions. So when we did this, we went through and did a comprehensive literature review, and this was really looking for any studies that examined in an empirical way. So this isn't the sort of talking heads paper kind of thing. This was more studies of evidence about what physicians know, think, and do with regard to considering resources. These are some of the search terms we used: resource allocation, scarcity, et cetera. We cross those with terms for empirical research like physician practice. Oh, I have one, but thank you. I'll take a sip in a minute. And then from articles we identified initially, we then kind of snowballed it by looking at their subject terms and also their bibliographies and going from there. Anyway, this is how you do sort of a systematic or comprehensive literature review. Then we took all that data and we have done an ethical analysis. So one investigator, that would be me, SDG right there. Oh yeah, I got a point over here. SDG, okay. Created an initial table that listed the professional values and norms found in those 4 sources: the code, the charter, trust and trustworthiness. There's a literature on that from Virtues in Medical Practice and some other places, and the framework for rationing by clinical judgment. So tried to sort of compare what's the data saying versus what are the norms saying, okay? And then, this whole team of people, which included Hurst, Danis, Tilbert, Matt Winia, Eric Campbell, a whole bunch of people who have some expertise in medicine and bioethics. They're all doctors, reviewed the summary of the literature, identified what they saw to be empirical evidence of any particular norm or value, and when they could, whether the studies were consistent with the professional norm or value or inconsistent with or sort of mixed. Then we all met and discussed what we all had found separately and have been putting it together. Now this is still kind of preliminary. We haven't quite finished writing the paper yet, but soon. And I'm just going to show you some of the results we came out with, because these are some of the things that we identified in the literature as being better, more known. There was more evidence about it. So, and this is my color code scheme where red, stoplight, inconsistent with norm, yellow, mixed, green, consistent. And so just to go over 4 different sort of norms or values that came from these 4 sources. 1, put the patient first. 2, inform the patient of all of their options. 3, physicians should have knowledge of the resources needed if they're going to be making judgments using that. And 4, consider only morally relevant criteria and respect the individuality of patients. So these are the 4 that I'll go through. There are others, but these are the only 4 I'll present today. So 1, place the patient first. Well, there was a study done here in the US, 70% of physicians agreed that the responsibility was to the patient rather than society. Canadian oncologists, by the way, this is all international, so some of this is US and some is not. Canadian oncologists were unwilling to accept limitations on what they could prescribe for their patients and described moral distress and uncomfortable discussions with patients. Norwegian physicians described demanding patients who came in conflict with their perceived need to be a gatekeeper, and they described times they just couldn't say no. The community tracking study, also in the US, physicians reported routinely considering patients' out-of-pocket costs when selecting drugs or care settings or diagnostic tests. Primary care physicians were more likely to do this than specialists. And in California, 60% of docs said it was more important to manage patient drug costs than total drug costs. In other words, what the patient's paying is important, what somebody else is paying, not so much. So that seems to be very consistent with the put the patient first. It's okay to consider the patient costs because, frankly, they want you to, most of the time, not always. But not so much anybody else's. So what about informing the patient of all the options? Well, the data here is a bit mixed. In a study in Europe, 4-country study in Europe, 82% reported explaining to at least one patient why an expensive intervention wasn't used. But over a third reported they sometimes didn't inform a patient of a more expensive treatment. Nearly all Denmark GPs considered the cost-quality trade-off relevant to their decisions. Only half said they would disclose that to patients. In an observational study, actually, in the US, over half of doctor-patient visits included medication changes. Only a third of those included any discussion of cost, and most of those were initiated by the patient. It was more common when the patient was white, when the doctor was white, and when the patient's income was middle income, basically, level. So, kind of mixed. Sometimes disclosing, sometimes not so much. What about our knowledge of resources needed? Well, pretty bad. This is just a couple of examples of the literature out there. There was a systematic review of doctors' knowledge of drug costs, and it's not very good. And doctors tend to overestimate the cost of cheap drugs and underestimate the cost of expensive drugs. This also tends to be true for other kinds of resources besides medications, but there's more data about medications than about just about anything else. So our knowledge of the resources needed isn't terribly good. Don't worry, I'll get to the good news in a minute. So consider only the morally relevant criteria and respect the individuality of patients. Well, one of the reasons I actually started this study in the first place was because I knew the literature on, or the old literature anyway, on the allocation of ICU beds. Okay? So doctors sometimes say, well, we shouldn't ration, we shouldn't be involved in making judgments about who needs what or whatever, but we do it all the time. We do it with our time, we do it with ICU beds, and the data on ICU beds actually is excellent. The patients, when there's a shortage of beds, and they've studied this in multiple countries, in multiple contexts, in lots of different kinds of institutions, when there's a shortage of beds for whatever reason, doctors tend to admit people who are more severely ill, okay? Sometimes they admit people who are likely to be younger, but the mortality rates and readmission rates tend to be unchanged. In other words, we do a pretty good job deciding who needs a limited resource of ICU beds. Now, there's some other differences. Israeli physicians viewed patients' quality of life as more important than US physicians. Most Israeli and European ICU physicians would admit a patient with survival less than a few weeks to the last bed. Only about half of US physicians would do that. In a study of Swiss ICU physicians, I better get another drink of water. They considered the following criteria important in deciding who gets an ICU bed: prognosis, patient wishes, but not socioeconomic status, religious beliefs, or emotional state. So this goes along with that sort of use morally appropriate criteria. Need is morally appropriate. Socioeconomic status, not so much. Okay? Patient wishes, certainly appropriate. Okay, so a few other studies looking at what criteria physicians have used when they're making judgments about resources or use of limited resources. Study in Finland, severity and prognosis should affect prioritization strongly, the doctor said. Wealth, poverty, and working status should not. In the UK, in this 4-country study in Europe, they were asked what sorts of cost containment policies they found more or less acceptable. They found evidence-based guidance, classifying referrals by urgency, and to some extent waiting lists for elective procedures to be more acceptable than some other ones. In a study of US nephrologists, patient and family wishes for dialysis was more important than was considered in Britain and Canada. That was a study done in the 90s. And finally, although this study has been quoted to show that doctors sometimes order unnecessary tests at a patient's request, I think a patient requesting something actually is relevant. So Campbell's study of, and there's another study from Norway, Carlson and Norheim, that say, when patients really want something, I'm more likely to get it for them. So now, while I don't think that should necessarily rule the day, I don't think patients have the ability to decide what they need, but I think weighing patients' values and preferences is morally relevant. So for considering only morally relevant criteria and respecting patient individuality, most of the evidence we found was consistent with that professional norm. So, physicians support some responsibility to be cost conscious. But what we found in the literature is the more tightly this is linked to withholding a benefit from a patient or withholding benefit from patients, the less likely they are to support it. Physicians are willing to consider costs faced by patients. Patients are more likely to begin discussion of costs than doctors are. Doctors tend not to know costs very well, which I think we could probably do something about. Although I'm not really in favor of the shopping cart version of the electronic medical record, which has been proposed by some. The data show that doctors kind of are inconsistent about disclosing when costs or resource limits are playing a role in their recommendations or decisions. But they do tend to consider appropriate clinical criteria: severity, prognosis, sometimes age. That's a mixed picture in the data, and what they perceive as the patient's quality of life, which, as I mentioned earlier when we were talking about end-of-life stuff, we have to be kind of careful about that, because doctors may value different things about the quality of life than our patients do. I think we have to be careful. So those are my conclusions from that study. I wanted to point out that there is new content in the Code of Medical Ethics on stewardship. Let's see if I can get them all out there now. Yes. And basically elucidates some of the things that we've talked about, and probably some others too, and that is to use evidence, to individualize care, to base recommendations on patients' needs, and choose actions that require fewer resources when the alternative courses of action offer similar likelihood and degree of anticipated benefit compared to anticipated harm. I had to read that one in full. So, but we also talk about being transparent about when resource constraints play a role. So if you're kicking somebody out of the ICU because there's somebody in the ER who needs a bed, say, you know, I have somebody else who needs this bed more than you do. Okay? I worked in the VA system for a while, and it was a lot easier, actually, to be honest about, well, we start with the cheap meds. If that doesn't work, we'll go to the more expensive stuff. That way we can take care of more vets. But it was a statement I could make honestly in the VA system that you can't really do so well in the private insurance scheme because the patients don't buy, literally, figuratively, that the money saved is going to benefit some other patient rather than a CEO or, I don't know, something. Insurance companies have become handy targets, I think, for patients and doctors. So, and the other thing is that we recommend that doctors participate in efforts to resolve disagreement, and we also obviously recommend a lot of things for the system itself so that physicians can exercise ethical stewardship, and not just be bean counters. And I wanted, before I finish, and I know I'm done soon because I love having time for questions, but I also wanted to put in a plug for the Wagner Lecture. Here, Jeremy Lazarus, who's the current president of the AMA, is going to be here on Halloween. And the Wagner Lecture will be on fixing healthcare the ethical way, and he's also giving psychiatry grand rounds that day on integrating psychiatry and medicine. And Dr. Margolis has organized all that, gets all the praise and thanks. I'm just advertising. So I'm happy to take questions, comments, or complaints.